Hi guys, welcome to our lesson on infants and children with special needs. For most of human history, infants and children with devastating congenital conditions or diseases either died or remained confined to a hospital. In recent decades, however, medical technology has lowered infant mortality rates and allowed for a greater number of children with special needs to live from home. Some of these infants and children include premature babies, infants and children with lung disease, heart disease, or neurological disorders, infants or children with chronic diseases such as cystic fibrosis, asthma, childhood cancers, and cerebral palsy. We also know that infants and children with altered functions from birth, such as cerebral palsy again, spina bifida, or other congenital birth defects, are all patients that would be included under those with special needs. In caring for these children, family members receive education relative to the special equipment that's required by the infant or child. So even though they may feel a great deal of apprehension when they move from the hospital to the home, as a result, they may summon EMS at the first indication of trouble. This is especially true in the initial weeks following discharge. Let's get into the rest of the lesson here. There's a couple things that we need to be aware of at first. First, I want to talk about home care devices, and then we'll jump into how to deal with these special needs children. Common household care devices are devices that you might commonly find in the home and include things like tracheostomy tubes, apnea monitors, artificial ventilators, central intravenous lines, gastric feeding tubes, gastrostomy tubes, and shunts, just to name a few. In treating children with special needs, remember that the parents and caregivers are often very knowledgeable about their own children and the devices that sustain their lives. Listen to them. They know their children better than anyone else. All right, let's jump into how we should communicate with our infants, or primarily our patients with special needs. We want to do a couple things here. First, we want to avoid using the term disability in reference to the child's special needs. Oftentimes, that's seen as a very derogatory term. Never assume that the patient cannot understand what you are saying just because they have a special need or disability. And involve the parent or caregiver as much as possible, if appropriate, in their treatment. We also want to make sure to treat the patient with special need with the same respect that we would any other patient. Some pretty common things, right? The golden rule: treat others as you would like to be treated. Now, we talked about some of those common home care devices and how the parents are going to be most proficient about that, but these include things like the tracheostomy tube and suction. Patients who are on prolonged home ventilators or who have chronic respiratory problems may have surgically placed tubes in the inferior trachea. A tracheostomy, or a trach tube, may be used as a temporary or permanent device. Although various types of tubes are used, you might encounter some of the common complications that go along with these tracheostomy tubes. Things like obstructions, usually caused by a mucus plug. Maybe the site will bleed, either from the tube or around the tube. There might be a loose tube causing an air leakage, or the tube may become dislodged, or even an infection that could cause a patient's condition to worsen in a case where they already have impaired breathing. Now, when we think about management steps for a patient with a tracheostomy, they include maintaining an open airway, suctioning regularly as needed, allowing the patient to remain in a position of comfort if possible, providing oxygen in these cases of respiratory distress, assisting ventilations in cases of respiratory failure or arrest by using the tracheostomy tube to ventilate, intubating orally in the absence of an upper airway obstruction, intubating via the stoma or the surgical opening in the neck if there's an upper airway obstruction, and then obviously transporting the patient to the hospital. Now, apnea monitors are used to alert parents or caregivers if the patient, child has ceased breathing, primarily in the infant, and especially those that are premature. Now, some of these types of monitors signal changes in heart rate, such as bradycardia and tachycardia as well, and they operate via pads that are attached to the baby's chest and connect to the monitor via wires, as you can see here on the image on the presentation. If the device does not detect a breath within a specific time frame, or the infant's heart rate begins to go too slow or too fast, an alarm will sound, allowing the parent or caregiver to begin to intervene. When an apnea monitor is placed in the home, parents are typically instructed on what to do if the alarm sounds, things like stimulate the child, provide artificial respiration, and so on. If these fail, EMS may be summoned. Also, nervous parents who just brought a baby home on an apnea monitor may panic the first couple times that the alarm sounds and immediately call 911. Try to be patient and be kind while instructing them what to do when these alarms sound. Now, not only are there apnea alarms and monitors that exist for special needs children, but also you can get these in little devices that attach to the patient's foot, onesies and sleeping sacks that actually have built-in devices. Oftentimes will give a false alarm to say the child has stopped breathing, and EMS will be summoned for those. Lastly, we have home ventilators or artificial ventilators. Various configurations exist for home ventilators. Demand ventilators sense the rate and the quality of the patient's respiration, as well as several other parameters, including things like pulse oximetry. They typically respond to the patient's limits. Other devices provide a constant PEEP or positive end expiratory pressure and a set oxygen concentration to the patient. Two complications commonly result in EMS being called. Either number one, a device suffers a mechanical failure, or two, there's shortages of energy during electrical failures, right? They don't have battery backup or the battery backup dies. Treatment typically includes, again, maintaining the patient's airway, administering artificial ventilations with an appropriate device, primarily BVM and oxygen, and then transporting the patient to the hospital until the home ventilator is again back and working. Other common devices that you may see include gastric feeding tubes and gastrostomy tubes. Children who are not capable of swallowing or eating to receive their nutrition either are going to get that through a gastric tube or a gastrostomy tube. A gastric feeding tube is placed through the nostril and into the stomach, and a gastrostomy tube is placed through the abdominal wall directly into the stomach. Now, these special devices are commonly used in disorders where their digestive systems are out of whack, or in situations where the developmental ability of the patient is hindered through regular feeding. Again, the food that they're going to take in is basically a liquid of nutrient liquid. There are some complications that can arise in these, and they include bleeding at the site, a dislodged tube, respiratory distress, most likely if the tube has migrated from the esophagus into the lungs, and now they're dealing with aspiration. And then in the case of diabetics, altered mental status because of loss or misfeedings. Now, emergency medical care involves supporting airway breathing and circulation, including possible suctioning and the administration of supplemental oxygen. Patients should be transported to a definitive care facility either in a sitting position or in a lying position on their right side with the head elevated. Again, the goal is to reduce the risk of aspiration because that is a serious condition in any pediatric patient. Remember, respiratory problems, in this case caused by aspirations of a displaced feeding tube, can lead to severe hypoxia, respiratory failure, and arrest and cardiac arrest. Now, shunts are another component. Shunts is a surgical connection that runs from the brain to the abdomen. It removes excessive cerebral spinal fluid through drainage. Now, a subcutaneous reservoir is usually palpable on one side of the patient's head, and a pathologic rise in intracranial pressure secondary to a blocked shunt is the primary complication that you can see. If the fluid can't drain off, intracranial pressure is going to rise. A shunt failure may also result in the shunt's connection being separated, and usually has to do because of a child's growth, especially during rapid growth spurts. Now, cases of shunt failure present as altered mental status. The patient may exhibit drowsiness, respiratory distress, the classic signs of pupil dysfunction or posturing even. Be aware that altered mental status may be caused by an infection, or a distinction may need to be made at the hospital setting if it's an infection or if it's related to some type of damage to the equipment of the shunt itself. Care steps to involve maintenance of an open airway, administration of ventilations as necessary, and immediate transport. Remember that shunt failures require correction in the operating room, where cerebrospinal fluid can be drained, or in rare cases, an infection can be identified and then treated. Again, we talked about the NG tube being placed on the nasal passage into the stomach for feeding. A duodenum tube is going to be where it goes directly through the small to the duodenum, also referred to as gastrostomy tube. And then we talked about parental feeding via IV when the GI tract is not working. So if we can't do it through the GI tract, there may be some type of IV fluids or nutrients that will be administered to the patient. Now, there are a couple things that we have to recognize as well, and these include, before we get into infants and children with special needs specifically, I want to talk about general assessment and management practices. Remember that the pediatric patient with special needs requires the same assessment as any other patient. Always evaluate the airway, breathing, and circulation, and you can recall this from the primary assessment when we look at disability, referring to the patient's neurological status, not to the child's special needs. That's a different version of disability on the ABCDE approach. If you discover a life-threatening condition, obviously during your primary assessment, you need to begin immediate appropriate interventions. Keep in mind that a child with special needs is often going to be undergoing ongoing processes. In most cases, you should concentrate on whatever the acute problem is and really, again, focus on their airway. Now, during your assessment, ask pertinent questions to the parent caregiver, such as what unusual situation called for you to contact 911, or why was EMS or the ambulance summoned? As we've already mentioned, the parent and caregiver is usually the most knowledgeable person about that patient's health conditions. In most cases, the physical examination is essentially the same as with any other patient, but it is important to explain everything that is being done. Even if the patient doesn't seem to understand, it's oftentimes very helpful for the parent or caregiver. And do not be distracted by the special equipment. Be aware that the help that the patient or parent or caregiver may be able to provide is there based on the fact that they have these home health devices and they're the experts in those devices. And in managing patients with special needs, keep these several thoughts in mind. Number one, avoid using the term disability. We talked about these earlier in reference to the child with special needs. Instead of think of them as what the patient has that the patient has many abilities, just has a few challenges. Never assume that the patient cannot understand what you're saying. That's oftentimes a very dangerous thing to do and can be extremely embarrassing and completely lack of professionalism. Involve the parents or the caregivers as much as you possibly can, especially in their treatment when appropriate. They can manage the illness or congenital condition on a daily basis, so oftentimes they can give you a lot of insight of what needs to happen, especially if you're not very familiar. Oftentimes they're more comfortable with certain things. And then treat the patient with special needs the same as you would treat any other patient with the full utmost respect. Now, there are some components that we look at when we think about special considerations with our pediatric patient. Some of the biggest ones that we deal with really are going to focus on things like cerebral palsy, microcephaly, spina bifida, tracheomalacia, I can never say that, and then spinal muscular atrophy. Now, when we look at multiple casualty incidents involving children, the criteria routinely used for triage of an injured or ill patient at a mass casualty incident is based on adult anatomic and physiological data. So we don't have a lot of feedback when it comes to PED. However, as detailed earlier, children respond to injuries and illnesses somewhat differently because their anatomy and physiology are different than that of an adult. Recognizing this deficiency noted the emergency physicians to actually develop what we refer to as the Jump Start system for pediatric trauma. The Jump Start Pediatric MCI triage tool is used to optimize the primary triage of an injured child in the mass casualty incident setting. It's used to enhance the effectiveness of resource allocation for all MCI victims, especially recognizing we oftentimes will focus in on the pediatric patients because we feel their needs are more pertinent than others. And we have to remember the needs of the many outweigh the needs of the few, says Star Trek. We also want to be able to reduce the emotional burden on triage personnel who may have to make rapid life or death decisions about the injured, right? So the Jumpstart provides an objective framework that really helps us make sure that we're triaged by us using their heads, not their hearts. We oftentimes want to treat our patients with our hearts, and we need to make sure with pediatrics that we're using our brains, or using our common sense as much as we can to fight off some of those components. We oftentimes also have to recognize, in addition, this system utilizes a minimum physical and emotional trauma to children from unnecessary painful procedures and separations from lost loved ones. Under triage is addressed by recognizing the key differences between adult and pediatric physiology and using appropriate pediatric psychological parameters as clear decision-making points. The Jumpstart triage system was designed for the use in disaster and multi-casualty settings and is not meant to delay for EMS or hospital triage. The triage philosophy of children with acute injuries may not be appropriate for the primary triage of children with medical illnesses in a disaster-like setting. Long story short, we need to make sure we have an effective tool to properly triage pediatric patients where we use our brains, not so much of our heart. When we look at utilizing the Jumpstart triage method, there's a couple things that we have to recognize with this algorithm. The entire category for the Jumpstart system is simple. That is that the victim appears to be a child, use the Jumpstart treatment algorithm. If the victim appears to be a young adult or older, use the START system. The START triage system we talked about previously in our MCI and incident management lecture. Here's how we utilize the Jumpstart system. First, we're going to identify and direct all ambulatory patients to the designated minor or green area for secondary triage and treatment. There we'll begin assessment of non-ambulatory patients as you come to them. Because children are less than 1 year of age, cannot walk, they should be carried over to the area where minor or the green triage area is by all of the other ambulatory patients. The next component we will do is to assess the breathing. If the child is breathing spontaneously, go on to the next step of assessing respiratory rate. If the child is apneic or with very irregular breathing, open the airway using a standard positioning technique. And if the position results in the resumption of spontaneous respiration, tag the patient as immediate or red, and then move on. If the child is not breathing after the airway has been opened, check for a peripheral pulse, and if no pulse, tag the patient as deceased or non-salvageable, and then move on. That can oftentimes be very difficult to do. Now, if there is a peripheral pulse, give 5 mouth-to-mask or mouth-to-barrier ventilations, and if the apnea persists after that, then we will label them as deceased or non-viable. And then we have to again move on to the next patient. If breathing resumes after the Jumpstart ventilation attempt, tag the patient as red and get moving again. The third component is to assess the respiratory rate. If the child's respiratory rate is between 15 to 45 per minute, proceed to the next step and assess for perfusion. If respiratory rate is 45 per minute or irregular, tag the patient as immediate or red and then move on. Step 4 is to assess perfusion. If the peripheral pulses are palpable, proceed to the next step of assessing mental status. If no peripheral pulse is present, and at least in an injured limb, tag the patient as immediate and then move on. Lastly, if the patient's mental status, we're going to use the AVPU scale to assess the mental status. And if the patient is alert, responds to verbal stimuli, or appropriately responds to pain, then we tag them as delayed or yellow and then move on. If the patient is inappropriately responsive to pain or unresponsive, then again tag them as immediate and red and then move on. Again, there are some modifications for non-ambulatory children. All non-ambulatory children must be immediately evaluated using the Jumpstart treatment algorithm. And then those that are too young to walk or who have developmental delays, or children with an acute injury that are prevented from walking before the incident, obviously maybe they have some underlying chronic disabilities. Any of these cases, you would label them as red, and then if the child meets the delayed criteria, then you tag them as yellow using these primary components. Again, delay or yellow is a significant external signs of injury are found, deep penetrating wounds, severe bleeding, severe burns, amputations, and so on. Minor would be considered of no significant external injuries that are there. The last part of the Jumpstart triage component is the reassessing of dead or non-salvaged victims, those that have been tagged as dead. Unless clearly suffering from injuries that are incompatible with life, the victim is tagged in the dead and non-salvaged category. They should again be reassessed once all the critical folks have been cared for. That includes all the reds and the yellows that are unseen. And then care should be taken to preserve the dignity of the dead. Just because they're dead doesn't mean we're not going to show them respect At the same time, we also need to be careful not to disturb any type of forensic evidence that may be present. In summary, we've talked a lot about pediatric emergencies. We recognize that pediatric emergencies can both be stressful for anyone, regardless of the situation, whether it's medical or trauma, if it has to do with assault, abuse, neglect, or mass casualties, or even those with special disabilities or special needs. We again must remember that pediatric patients are not just small adults. And in order for us to be successful in our managing of these patients, we have to perform a detailed assessment focusing on the needs of our patient and their anatomical and physiological development. I hope this lesson has been helpful for you, and we'll catch you on the next one.